Greetings, ladies and gentlemen. It's my pleasure and a privilege to discuss with you the most recent guidelines for hypertension, which which were released by the American College of Cardiology and American Heart Association just a couple of days back. This is a document on the latest guidelines for hypertension prepared on behalf of several organizations, but the most important organizations in the group are American College of Cardiology, American Heart Association. So the document is the latest guidelines for hypertension 2025. As some of you know, the last guidelines released by American College of Cardiology and American Heart Association was in year 2017. Since 2017, there were two other guidelines that became available. One was from the European Society of Hypertension in 2023, and the other one was from the European Society of Cardiology in year 2024. Thus, the latest guidelines released on August 15th are from American College of Cardiology, American Heart Association, and other affiliated organizations. I'm going to cover certain salient features or special attributes of the new guidelines, and I'll try to compare them with the previous guidelines. So the presentation that I'm going to make is nothing but a synopsis of the new guidelines, but the original document is quite large, more than 100 pages. But for your convenience, I'm going to provide a synopsis of the latest guidelines from American College of Cardiology and American Heart Association. And let me go through some of the important features of these new guidelines, and then you can determine which aspect of guidelines are most applicable for you in your clinical practice and in your communities. That has to be individualized. The important aspect of the new guidelines is they used a PREVENT score, which is Prevention of Cardiovascular Event Score, instead of Personal Cardiovascular Event Risk Stratification. So one major feature of the new guidelines is they use PREVENT instead of PCE risk stratification, which is estimate the risk of cardiovascular events over a 10-year period. In the new guidelines, I'm going to cover just certain key features. The term hypertensive urgencies is completely removed, and it is now known as severe hypertension. There are new targets for blood pressure control in patients with acute stroke. In the past guidelines, resistant hypertension and pregnancy hypertension were separate documents, but in the new guidelines, both pregnancy and resistant hypertension have been incorporated into the main document. One feature of the new American guidelines in the choices of pharmacological treatment is their reference to the use of diuretics in the treatment of hypertension. So the classes of drugs that they have recommended for pharmacological treatment of hypertension are diuretics, calcium blocking drugs, ACE inhibitors, ARBs, preferably in combination. Among the diuretics, which have been part of all guidelines since guidelines were established for hypertension, This new guidelines also includes diuretics in the initial choice of therapy. One thing very interesting is they have not used the word thiazides in the diuretics. They have used the term thiazide type diuretic in the pharmacological choices. All the previous guidelines use the word thiazides, but the new guidelines use the term thiazide type diuretic, which is an important point to consider. Among the thiazide type diuretics, they have listed chlorthalidone on the top because of its longer half-life and efficacy compared to thiazides. So this is an important special feature of the new guidelines is the utilization of the term thiazide type rather than thiazides, and they have given chlorthalidone as an example of thiazide type diuretic because of its efficacy compared to thiazides and long duration of action. The blood pressure goal in the new guidelines is to achieve a level less than 130 by 80 and if possible to 120 by 80. In the last guidelines of 2017, the blood pressure target was less than 130 by 80 millimeters of mercury. In the new guidelines, the target is still preserved, namely by 130 by 80, but they have recommended to achieve a blood pressure less than 120 by 80 if it is feasible, and this is an important feature of the new diuretics. This is a table that I'm showing, which is from the new guidelines. And this particular table refers to thiazide type diuretics. As you will notice, the agents recommended for initial therapy, thiazide type diuretics, and they have recommended chlorthalidone on the top, followed by hydrochlorothiazide, followed by indapamide. And recently, low-dose chlorthalidone was approved by US FDA for the treatment of hypertension. So this is a new table in the new guidelines compared to the previous guidelines from US and from Europe. There are other features that of the new guidelines which are shown on this slide that they have emphasized the relationship between blood pressure and cognitive function. They emphasized that high blood pressure is responsible for increased onset of dementia in all age groups. So we have known that for quite some time, but the new guidelines are linking the blood pressure level to the cognitive function, which is very, very important for all the practitioners who treat patients with hypertension, that by aggressive treatment of hypertension, you preserve the brain function and you decrease the onset and progression of dementia. There is also an important segment on blood pressure levels in pregnancy, and this will be covered in full document. But what they recommended is if the blood pressure is greater than 160 by 100, during pregnancy, blood pressure levels recorded 15 minutes apart, it is considered a significant hypertension in pregnancy, and they have recommended appropriate management of high blood pressure in pregnancy. The normal blood pressure in the new guidelines is less than 120 by 80. So remember, in the last guidelines, the normal blood pressure was less than 130 by 80, but in the latest guideline, the normal blood pressure is less than 120 by 80 millimeters of mercury. The guidelines recommend that if a patient has diabetes and hypertension, and if the blood pressure is more than 130 by 80 millimeters of mercury, it should be treated immediately without waiting for a longer period of time. And this is a new recommendation, is that patients who have diabetes and hypertension If the blood pressure is greater than 130 by 80, it should be managed appropriately. Now, I mentioned to you that normal blood pressure in the new guidelines is less than 120 by 80 millimeters of mercury. Elevated blood pressure is a new column, it's a new phrase in the current guidelines. Elevated blood pressure is something that is between 120 to 129 millimeters of mercury systolic and less than 80 millimeters of mercury diastolic. So let me state again that normal blood pressure is less than 120 by 80. Elevated blood pressure is 120 to 129 by less than 80 millimeters of mercury. Stage 1 hypertension is defined in the new guidelines as a blood pressure between 130 to 139 millimeters of mercury by 80 to 89 millimeters of mercury. So this is a new stage for hypertension in the recent guidelines. Stage 1 is 130 to 139 by 80 to 89. Stage 2 is a blood pressure greater than 140 by 90 millimeters of mercury. So there are 4 classes of blood pressure. One is normal blood pressure, one is elevated blood pressure, one is stage 1 hypertension, and the other is stage 2 hypertension. The new guidelines recommend that in the management of people with high blood pressure, one should have a team approach where doctors, healthcare providers, dietitians, nurse practitioners, and psychologists, they form a team if needed so that you provide optimal treatment. So they emphasize the importance of shared medical care in the new guidelines. Like previous guidelines, there is emphasis on accurate blood pressure measurement. So the new guidelines once again suggest that the blood pressure should be measured accurately in a sitting position with an automated office blood pressure. So not manual blood pressure, but with an automatic device in a seated position, 2 to 3 readings, and average of that is considered the accurate blood pressure measurement, and that is again emphasized in these guidelines. So why is that the new guidelines recommend a blood pressure level that is lower than the previous guidelines? And I'm going to show you some data. And these are the data that were used by the guideline committees to recommend the blood pressure. It should be less than 130 by 80, and if possible, it should be less than 120 by 80. So some of you might ask, what is the evidence to lower the blood pressure to less than 130 by 80, preferably to less than 120 by 80? And I'm going to show you a couple of studies. And this particular study that is shown on the screen included 34,000 patients with hypertension who were followed for 3 years. You look at the outcomes, those patients whose systolic blood pressure was less than 120, they had better outcome compared to those who had blood pressure less than 140. Even the mortality rate was much less in people with systolic blood pressure less than 120 compared to 140. And this is what is shown on the next slide. This is a slide looking at the blood pressure levels of 120 or 140. You will notice in terms of primary events, secondary events, or mortality, all these categories, those individuals who had a blood pressure less than 120 compared to 140 had lesser events and even lesser mortality. On the basis of this kind of a study, the new guidelines suggest, if possible, try to get the blood pressure less than 120 based upon the data like this showing that systolic blood pressure less than 120 is associated with reduced morbidity and reduced mortality. There was another study that the guidelines committee also quoted, and this is a study called Esprit study, where they compared 120 millimeters achieved goal blood pressure versus 140 in 10,000 patients, and the patients were followed for 3.5 years. You will notice, like the previous study, those individuals who had a blood pressure less than 120 compared to 140 had lesser incidence of cardiovascular events, and they had lesser incidence of stroke, and they had reduced risk of mortality or death rate. So when you look at outcomes and morbidity and mortality, all of them were significantly less in patients who achieved a goal blood pressure less than 120 compared to those whose blood pressure was around 140. And let me show you the graphics in the next slide. This is a slide from the previous data looking at systolic blood pressure less than 120 compared to less than 140. You will notice that all the cardiovascular events and stroke and death rate were significantly less in patients who had a systolic blood pressure less than 120 compared to 140. On the basis of these studies, the new guidelines are recommending that if possible, they're not mandating, they're saying if possible, try to get the blood pressure to systolic blood pressure less than 120. The goal blood pressure is very similar to previous guidelines, namely 130 by 80. But the new guidelines are trying to push the medical community to see if they can achieve a systolic blood pressure less than 120 if possible, due to the studies like this, which have shown systolic 120 is much more cardiovascular protective than 140. So, ladies and gentlemen, then let me conclude by remarking further on the new guidelines. The new guidelines from American College of Cardiology and American Heart Association for the treatment and management of hypertension were released on August 15th, and I have already given to you the classification of blood pressure according to the new guidelines: normal blood pressure, elevated blood pressure, stage 1 hypertension, stage 2 hypertension. The new guidelines have eliminated the category of hypertensive urgencies, and they have replaced with the category of severe hypertension. The new guidelines have a large section on resistant hypertension and hypertension in pregnancy, and I would ask the viewers to refer to the full document on these categories if they're interested. So what they would recommend now is in people who have elevated blood pressure or stage 1 hypertension or more, one would recommend lifestyle changes for about 3 to 6 months, namely reducing the salt intake, increasing the potassium intake, increased physical activity, reduction or elimination of alcohol intake, and regular lifestyle changes for 3 to 6 months. If the blood pressure remains elevated, then they would recommend pharmacological reduction of hypertension using diuretics, RAS blockers, and calcium channel blocking drugs, preferably in combination. They strongly recommend fixed dose combination is superior to giving two separate drugs individually. So the new guidelines once again emphasize the importance of combination therapy for pharmacological reduction of hypertension. There are no special features with calcium channel blocking drugs or RAS blockers in the new guidelines compared to the previous guidelines. However, in terms of diuretics for the choice of treatment, the new guidelines use the word thiazide type diuretic for the initial management of hypertension, either as monotherapy or preferably in combination with other types of antihypertensive drugs. And among the thiazide type diuretics in the table, chlortalidone was listed, followed by thiazide, and followed by indapamide. And the other combinations are also extensively listed in the full document, which is about 100 pages. So the new guidelines are somewhat similar to the previous guidelines, but the goal blood pressure, if possible, they would like for you to drive it to less than 120 by 80. And patients who have diabetes and hypertension want to start pharmacological reduction of hypertension as quickly as possible. Resistant hypertension and pregnancy are described in detail. I mentioned to you earlier that they removed the word hypertensive urgencies and replaced it with severe hypertension. So, all in all, this document is a slight improvement or broadening compared to 2017 guidelines in terms of the level of blood pressure and in terms of other changes one has to make in order to reach the goal level of blood pressure. So my suggestion for all of you, I have just given you highlights, special features or synopsis for your consideration. And you can also refer to the full document for which you will have access very soon. And you can select what aspects of the full document are most applicable to you and to your patients and to your community as you identify and manage patients with hypertension with practical application of the new guidelines for the treatment of hypertension. Let us hope that we will further reduce the onset and progression of cardiovascular disease. Let us hope that we will reduce the onset and progression of cerebrovascular disease. Let us hope we arrest the onset and progression of chronic kidney disease. Let us hope that we reduce the incidence of dementia and improve the cognitive function. So the overall health of the patient is best maintained by a broad and systematic approach using the principles that I have mentioned during my brief narrative. As I said earlier, the full document is also available for your consideration. I just have given you certain bullet points. I hope that will help you and assist you in the management of patients with high blood pressure in your clinical practice. Thank you for your attention and my very best wishes to you, your patients, and the community at large.